Now, in addition, there are 3 or 4 very exciting drugs that are probably going to build into these and result in multiple novel combinations, very similar to what we see in multiple myeloma, where we're now entering triplet combinations that could give us very high response rates with little to no chemotherapy. And so those 3 drugs at this time that are very exciting are, we have the Venetoclax, which is showing very nice activity in acute myeloid leukemia, especially when combined with azacitidine. So in the frontline study of azacitidine with Venetoclax, we have now 200 plus patients. The overall response rate is 73%, and this is very important because historically in the same elderly unfit population with azacitidine or decitabine alone, the response rates have been 18 to 25%. So we are not seeing doubling, actually tripling of response rates. And more importantly, we're also seeing that the survival is also very dramatically improved. So now in elderly AML with Venetoclax azacitidine, we are seeing 2.5-year survival rates of 45 to 50%. Historically, we would see these survival rates of 12 to 20%. So again, more than doubling survival, and for the first time we have a realistic chance of telling our elderly unfit AML patients that they have a very good chance of being alive 3, 4 or more years from now. And so this is very, very exciting across the board, because this is not something we ever had for 4 to 5 decades of AML therapy. And then the 2 other major drugs are also new FLT3 inhibitors. One of them is a drug called Quizartinib, which recently, a few weeks ago, released positive data in their randomized phase 3 study in the relapse setting. So they took relapsed FLT3 mutated AML, treated them with Quizartinib alone versus combination chemo, and they have shown a significant overall survival benefit with the Quizartinib. And I think this is also very important because the randomized arm was actually chemotherapy, and some patients were receiving 3 drug chemotherapy regimens. So you have 1 oral drug, very well tolerated, versus combination chemotherapy like FLAG and MEC, and yet the drug actually improved both response rates and survival. So this shows the power of targeted therapy, where they can work even better than 2 or 3 drug IV chemo. And then the last drug also is Gilteritinib, which has very, very similar activity, very similar response rates in the bone marrow of about 50% to Quizartinib, and also seems to be a very powerful, potent FLT3 inhibitor that is moving forward. So I think now the next big step for us here is to see how we can use these agents, which are all showing incremental benefit, but not really a clear home run. And can we now start developing frontline treatments such as Venetoclax and add maybe a FLT3 inhibitor, or maybe a PD-1 inhibitor, or maybe an MDM2 inhibitor in the right setting with the appropriate dose modifications and monitoring, and get this 45-50% to 65-70%, because once we get to that point, then we are actually getting response rates and survival similar to standard chemo. And the hope and the dream, and a lot of our efforts at MD Anderson are, can we now move into myeloma-like territory where we can reduce or even avoid chemotherapy for AML in 3 to 4 years. And I think we have the tools, we just have to develop them appropriately and do the trials.